Welcome to the Therapeutic Management of IBD, the Paradigm Shift to Personalized Care Symposium. This section of the webcast is titled Personalized Medicine in IBD, Choosing the Right Drug for the Right Patient, presented by me, Michelle Rubin. Once you have completed this activity, you will be able to explain how treatments are personalized to the patient using treatment algorithms and selected approaches for delivering IBD care. I hope you enjoy the presentation. So I'm going to talk about how we personalize the medicine, meaning right drug for the right patient. All right, so how has treatment evolved? So there's been shifting treatment paradigms. We started out, you remember hearing the step-up approach, where patients actually had to earn their right to the treatment from the lower, more mild type treatments up to the more severe disease type treatments, but they had to go through that process and earn their right to get those. And then we had the top-down approach, where we were, giving patients all the severe level type drugs, the biologics, but that isn't appropriate for everybody, nor is it cost effective. That was another approach that doesn't quite work or meet the needs of our patients. And so we're now at personalized treatments. And what does that mean? It's a broad statement that talks about using right drug, right dose, right patient, right route at the right time. It's therapies derived from what basically Lara was somewhat talking about, the genomics and the microbiome. It's using biologic markers that can predict the risk of disease or response to treatment, that we can make a prediction ahead of time as to what drugs they might need. And this also involves patient involvement in the decision-making process and getting involved in self-management, because that's how we're going to promote adherence. So it also involves this comprehensive IBD management, and you can see there that we're talking about controlling symptoms, we're treating inflammation, looking at complications, but also looking at the patient and providing emotional support. We want to prevent cancer. So this is a full circle of all-around treatment for these patients. And we also know that treatment can alter the natural history of Crohn's disease. We know that treatments can help induce and maintain gastrointestinal severities. We know that it can prevent strictures and fistulations and complications. And we know that it can prevent extraintestinal manifestations as well. It will decrease hospitalizations and surgery, and it also can help decrease the long-term cost of their care. So this is looking at somewhat the step up that we were talking about earlier, but the difference is that now what we're going to do is look at the severity. And we're going to look at the severity of the patient's disease, and then we're going to incorporate the appropriate treatment at that level. So for moderate to severe disease, we're going to start looking at the biologic level, or using some of the immunosuppressives. And you also see that we're going to induce remission, and then you see the dotted line at these therapies where we're going to then utilize maintenance management. The top-down theory was use of biologics early in treatment, but we know that, and we do know that using them early is good instead of late where we have the complications of surgery. So it's utilizing really risk management and looking at prognostic markers as to where our treatment is going to go. So what does the right drug choice mean? For ulcerative colitis, it's looking at the 5 ASAs, it's looking at thioprins, the anti-TNFs, and the anti-integrins. For Crohn's disease, we look at the thioprins, methotrexate, anti-TNFs, and the anti-integrins. So here's just what some of the prescription meds are. Your immunologic agents are your azathioprine, the cyclosporin, the 6-mercaptopurine, methotrexate, and the tacrolimus, and then you've got your biologic agents, which are adalimumab, the certolizumab, infliximab, natalizumab, vedolizumab, blah, 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 blah. I always think about how do they get these names. The right dose. So how are we going to get the right dose? We're going to start doing therapeutic drug monitoring, and we've been doing this already with the thioprins. But it's dose adjustment and titration that's based on blood drug concentrations, looking at antibodies, if they've developed or not, and enzyme activity. And with therapeutic drug monitoring, we have the potential to minimize toxicity, and we want to maximize the effectiveness of the drug that we're using. So right dose, again, TDMs for thioprins. We know that the primary enzyme for metabolizing azathioprine and 6-MP is the thioprin methyltransferase. And we know that we need to check enzyme activity because we want, and this is more cost effective. If we know these drugs are able to be, are going to be effective and work, you know, we want to make sure that we're not just using them and they aren't effective and it's a waste of money. And we want to be sure that it fits for the genotype. So 90% of patients have normal TPMT, 10% have the intermediate activity, and 0.3% have negligible enzyme activity. So we want to check along with this the CBCs, LFTs, amylase, and lipase because these levels can also often be elevated, and we want to check for decreased white counts in these patients. So the right dose, it's helpful to assess for lack of response, if they're going to develop elevated liver enzymes, leukopenia, and also we need to also evaluate patient adherence. Are they really taking their drug? And we can if the levels are off, either it's not the right drug, they're not taking their drug, etc. But we still have to do the lab monitoring, so it's not a substitute. We still got to check the CBC and liver enzymes. And down there I have the the theoguanine and the 6-methyltransferase normal levels and what we should be looking for. So the right dose for the anti-TFs. Why is this important? Because 10 to 30% do not even respond to the therapy. 40% lose response over time. And we also know that they can develop drug antibodies, which decrease its effectiveness. And measurable drug levels we know at trough are associated with an improved response rate. So we got to be sure that we've got good trough levels. We want to reduce adverse events that are associated with super therapeutic drug levels. And all of this is actually more cost effective than just empiric dose intensification. Let's just increase the dose. We need to be looking at levels. And this here is just a diagram showing variables that are affecting the TNF alpha inhibitor levels. Remember, this was one of your questions. All right. The immunomodulator usage, we know that it can decrease antibody formation. As you can see on there, it can decrease drug concentrations, and it can also it can increase drug concentrations. It can decrease drug clearance. And antibodies, if they're present, they decrease drug concentration and they increase drug clearance, meaning the drug is cleared out of the body very quickly. Male gender increases drug clearance. So when the drug is being cleared more quickly, probably means we need to up the dose of the drug or the intervals of the drug because it's being cleared more. Low serum albumin, another one to increase drug clearance. High baseline CRPs, also increase drug clearance. High body mass, our patients, and we see this often, we have some overweight patients, they may need more drug on board. And a high baseline TNF concentration. increases drug clearance. So there's 3 tests currently available that are out there to check for antibodies and drugs, and you can see them here, but it still is not, there's the clinical significance of detecting levels of antibodies in the presence of adequate trough levels is still unclear, it's still being investigated. TDM algorithm, here's an algorithm to help us in our practice that is looking at the loss of response to infliximab adalimumab levels. So if we get a loss of response, let's measure those levels and antibodies. And if a patient, and we're checking the levels, and infliximab and adalimumab is undetectable, and they have no antibodies, what would we do? Increase the infliximab and adalimumab dosage. If they have detectable infliximab and adalimumab levels and negative antibodies, so then you see on the diagram, you look at the infliximab adalimumab levels, and if they are low, increase the doses. If on the other hand, you see the infliximab is high as well as the adalimumab that's greater than the 5, this means they've already got an adequate dose on board and it's not working and they don't have antibodies, then we need to switch to another drug class. Does that make sense to everybody? Okay. And then in the last one, the drug level is detectable or it's undetectable, as you can see here, but they've got positive antibody levels, meaning it's going against the drug. You can see in the situation here, high antibody levels, titers are high, switch to another. If they have low antibody levels and titers, you could either try and increase the infliximab or adalimumab or switch to another. So there's all algorithms that are there to help us determine the right level of drug, or if we know a drug's not going to work, then we got to switch to another class from the, within the biologics. If the anti-TNFs aren't working, then we got to switch over to the certolizumab, the anti-integrins. So right dose, treat to target. Symptom relief is important, but does not always correlate with inflammation. Does that make sense? This was our old way of thinking, that we were treating patients according to their symptoms, but we know that when we go in there and look with a scope, it's not at all correlating with what's going on inside with the inflammation. Patients can be in remission, but yet we think they're in remission. When they're non-symptomatic, we go inside and we look, and they have active inflammation. So this concept uses serial evaluations of inflammation. The biochemical, looking at CRP levels, looking at our drug levels, antibody levels, looking at fecal calprotectin. All right, that's another test that shows if the bowel is leaking leukocytes, meaning there's inflammation ongoing. Radiological tests, it's doing, looking at maybe enemas, our barium studies, our CT enterographies, small bowel follow-throughs, and then endoscopic mucosal healing. Looking, seeing with our eyes what's actually going on in there. So it's a combination of all these things that we're going to look at to see what's happening with the patient. The right patient, talk about risk stratifying, checking are they mild, do they have moderate, or they have severe disease, and what do we look at? What are the characteristics? If they have inflammatory disease, do they have fibrotic, like stenosing type stricturing disease, or do they have penetrating disease with fistulas? The extent, is it local or is it diffuse? Is it throughout the entire colon and into the small bowel? And do they have complications associated with it? These are all risk stratifying factors. The right route, Laurel went through a lot of that. The mesalamine, sulfasalazine, delivered in the colon. Antibiotics, colon, pouch, treat for the terminal ileal disease, budesonide. She sort of went through all of that. Also looking at right route, the mild to severe, we've talked about. Oral versus injection or intravenous therapies. What works for the patient? What might be best? Some patients may not be able to give themselves injections. They'd rather go in for an infusion. Insurance is also a factor in this, right? Because some patients can't get the drugs because maybe their insurance won't pay for it. So sometimes insurance is dictating there, but we have to be patient advocates, and whenever possible, we need to try and make sure that we can get them the right drug. Patient's lifestyle and choice. Maybe they can't come in for infusions. You know, there's different things in their life that they help in that decision making as to which treatment. The right time for Crohn's disease, consider top-down therapy. And these are some of the characteristics: the young age at onset, fistulizing stricturing disease, perianal disease, cigarette smoking, upper GI, etc. And I'm showing you this here because this is a treatment algorithm for Crohn's disease. As you can see, mild disease in the green over there, and we have the moderate disease in the middle in the yellow, and the severe disease. And as you see, for severe and moderate, we start out perhaps with maybe prednisone first to induce remission and an anti-TNF. So it's sort of a decision tree that's based on the severity of their disease. And one thing I want to mention in there also is we are assessing at different points. They will have a colonoscopy or an ileocolonoscopy perhaps at 6 months, maybe 12 months, a year. Or we're going to be checking CRP levels, we're going to be doing fecal calprotectin, we'll look at drug levels, all of that is intertwined. The right time for postoperative Crohn's disease, there's the relative risk factors, early age of surgery, short time for first surgery, and the ileocolonic disease, active cigarette smoking, once again, that always comes up, penetrating, fistulizing, etc., you can see there. And here's an algorithm that we have that's for post-op recurrence algorithm. Once again, we're stratifying patients according to mild, moderate disease. Right time for ulcerative colitis, introduce combination therapy early when there's a high risk for a colectomy. When your CRP level is elevated and they have a high number of bloody bowel movements, they've got a low albumin, high fecal calprotectin, and the endoscopic activity index we also look at. And here's the algorithm, once again, for ulcerative colitis. All right, so patient engagement in personalized care, we're looking at complementary algorithm-based decision making. It involves use of telemedicine. We're keeping in contact with our patients as to what is going on. Home biomarker testing. This is a possibility also, and that is being looked at, where patients can do their own home testing and give us feedback on the results. Use of internet-based management tools, for example, the CCFA GI Buddy, where they're actually documenting their stools, their pain, if they're having stress. All of these tools together combined with our algorithms, our decision making, is all what personalized medicine is going to look like here with patient engagement, and that's the key. Patient self-management studies, I put these up here because there are two of them that we're looking at patients completing the fecal calprotectin weekly and also looking at the Crohn's and colitis activity index scale, utilizing results that then the dose can be individualized. And actually this involves the patient. They're finding that there's more improved adherence. And then there was another Copenhagen study where they were looking at patients completed weekly Harvey Bradshaw index, the piece that they could complete with the fecal calprotectin, and then 4 weeks post infusion data was entered, and they were flagging sort of using a traffic-like fashion. Red meant there was severe disease activity when these values were looked at, yellow, moderate, green, etc. And then they were using, adjusting the doses compared to this activity. So you're going to see a lot more of these kind of studies coming out as we're moving this way. So what is the nursing role? Currently, we know we do lab moderating, we do patient education, we reinforce adherence strategies all the time. But what is new here? We're identifying resources more for self-management. You know, a lot of patients using the apps and online tools, which they love to do, telemonitoring and triage and data collection in conjunction with the self-management. It's us in combination working with them to get this data together. And this was just a patient just showing what does personalized IBD treatment look like. You've got a 45-year-old pediatrician, has moderate to severe pan-UC, presented with a 20-pound, so there was a risk stratification, moderate to severe. He presented with these symptoms. We were looking at the hemoglobin, albumin were low. We started steroids to induce remission, but he was unable to taper without recurrent symptoms, so we moved to the biologic. That was the plan because he was at moderate to severe. And patient said, I want injectable because I can't be away from my practice. So he was willing to do the injectables. And 3 months later, improvement, but some breakthrough. So levels were checked. He had no antibodies. Drug level was low. So we considered maximizing the current therapy because he had no drug antibodies, correct, against it. So we elevate the drug level. That's what was missing. And the other thing, combination therapy, looking at adding a thioprin there as well. Thank you.